So at the outset, so the topic of today's panel discussion is de-escalation in breast cancer and the role of imaging. And at the outset, I would like to introduce my panelist, Dr. Meenu Walia, who is the Senior Medical Oncologist at Max Institute, Delhi, Dr. Kanchan Kaur, who is the Director of Breast Services in Medanta Hospital. Then we have Dr. Smriti Hari, the professor in AIMS Hospital Radiology Department, and Dr. Sangeeta Taneja, who is the senior radiologist in Apollo Hospital, New Delhi. So coming to de-escalation, so we have seen there are a number of trials going on, and we have analyzed few of them today. And it's really finding the optimum balance of sufficient amount of treatment. So oncological output are at their maximal efficacy, but not over treating and going on to the other side of the curve into the realm of unnecessary or unneeded toxicities. So trying to understand the de-escalation. So we all are very well aware with de-escalation in the breast. So it started with radical mastectomy in the olden days. From there, it came to modified radical mastectomy, and then to total mastectomies and lumpectomies. So for the smaller tumors, we were doing lumpectomies, but for larger, we were doing total mastectomies. And with this, the role of imaging became more and more important. As the patients were going for lumpectomies, it was very important that, a good work was done for tumor mapping using mammography, ultrasound, as well as MRI. And then we learned the skills of wire localizations and even bracketing wires so that we could help our surgical colleagues in removing those small cancers using lumpectomies. And as we went ahead, it came to a stage where even the larger tumors were given post-NACT. They went for lumpectomies, and then we started on and acquiring new skills. We were clipping the nodes and then putting the wires, and lumpectomies were being performed. So we have seen a lot of trials around de-escalation in breast cancers. So basically what we are trying to do is de-escalate or reduce the oncological treatment if we can do that safely. And for that, it's very important to identify the right subset of patient, as well as de-escalate in the realm of surgical procedures. So once we come to de-escalation of chemotherapy, can I ask Dr. Meenu Walia, ma'am, can you tell us which are the areas where you safely feel that you can de-escalate the standard medical oncological treatments in patients of breast cancer?
Dr. Jyoti, we have enough data from I-SPY 2, if we see that we can predict responses to neoadjuvant chemotherapy on the basis of radiological data also. And there are places where you can de-escalate therapy or even escalate therapy depending on the responses. For example, in today's world, in breast cancer, for most of the HER2 positive breast cancers and most of the triple negative breast cancers, we are now moving towards neoadjuvant chemotherapy, neoadjuvant therapy. And after neoadjuvant chemotherapy, we complete the courses of neoadjuvant therapy and then subject these patients to surgery and look for pathological complete response. For example, in HER2 positive, if there is a pathological complete response, then my decision whether I continue with the same targeted therapy or a double targeted therapy or change the targeted therapy, that is to change over to TDM1 or upgrade the therapy, will depend on pathological complete response. So at present, we are depending on our histological parameters to tell us whether the patient is doing very well, and this is the subgroup of patient who will have a good prognosis. We can either de-escalate the therapy, or even if the patients have not received a pathological complete response, whether we need to upgrade the therapy. That may depend on these kind of parameters. And I feel in the future there will be a lot of aid, as per the what we gathered from this SABCS, lot of aid, lot of potential to imaging, aid by our imaging techniques also, that can probably predict. Like there was a school of thought from I-SPY 2 only. If a HER2 positive patient is receiving a neoadjuvant therapy with targeted and taxane, and the patient shows a very good response, do I still subject the patient to anthracyclines, or I can omit anthracyclines? The same goes for triple negative breast cancer. A patient showing a very good response, do I add platinum in a triple negative breast cancer in the neoadjuvant setting, or I omit platinum? Because it is known that the minute I add platinum, the toxicity, the side effects of therapy is going to be much higher. So these are the things which we are looking forward, and probably we want to get answers from our radiological colleagues, from our pathological colleagues, which help us in deciding that how can we de-escalate or escalate therapy.
Right. Thank you, Dr. Meenu. That was really quite informative. So can I ask Dr. Sangeeta, what do you think would be the role of imaging in predicting response to treatment? As Dr. Meenu said, if we can predict response early on the treatment, it will really help them to de-escalate or escalate or make informed decisions regarding the further treatment for breast cancer. So, Dr. Sangeeta?
So as we have already seen, we have listened to our speakers. There are a lot of trials that are going on which are evaluating this role. And there are multiple parameters in MRI, both pre-contrast and post-contrast parameters, which can, which individually or collectively can help and predict the response to neoadjuvant chemotherapy as soon as after the first cycle of chemotherapy. And as the last abstract that I presented, in that even the baseline parameters of MRI can, to a certain level tell us which patients are going to go ahead with a pathological complete response and which patients are unlikely to show a pathological complete response. So I just prepared this list to just emphasize that MRI has been blessed with so many parameters in its kitty that can be used to assess the response to chemotherapy as a baseline and on follow-ups as well, as early as after the first cycle of chemotherapy, mid cycles, and of course our complete response after the completion of the NACT.
Right.
So,
yeah, go ahead.
No, these are just the parameters which have been discussed extensively. And for example, we can say that the ECRIN 6698, which is a offshoot of I-SPY 2 trial, in that the tumor ADC demonstrates the potential as a biomarker for assessing the early response to immunotherapy as well in the neoadjuvant setting for high-risk HER2 positive breast cancers. And even the I-SPY 2 trial, which is being talked about, in that also the functional tumor volume calculations, the reduction in the functional tumor volume can predict differentiate the responders and the non-responders as early as 6 weeks of chemotherapy.
Right.
But I think specificity, yeah.
Yeah. But I think in our clinical scenario in the Indian population, where getting even a single MR is so difficult, because most of the patients don't have insurance and they have to pay from their pocket. So having those follow-up MRs that we were listening to in the abstracts that were presented, I really feel it might be difficult in our scenario, but the kind of work that, poster that you had presented, where it was like, okay, one baseline MR, yes, it's still a feasibility, and if we can derive information from that one baseline MR, those kind of the research works that we should really look at, and we need to validate our work in our own Indian population, because that is something I still feel would be feasible.
That is
Doing
doable. Yeah.
that is something doable. Yeah, having repeated numbers of yes, in setups like AIMS, and where patients are not paying it from their own pockets, it might still be in the government setups. It can still be taken up there as research work, but in the private setup like yours and mine, it might become a little constrained there.
Absolutely, absolutely.
Right. And what do you think about the other modalities like PET and contrast enhanced mammo or ultrasound? Could they predict? Because, like, suppose ultrasound, it is very easily manageable. It's available everywhere, and somehow even PET. I don't know why patients still would find it difficult to get a MR done, but most of the people, they are, the first thing that they say, PET nahi kara rahe kya aap hamara? So PET, I don't know, has a more acceptance among the patient. So how about those? Can they help us?
Yes, of course. PET definitely adds to the imaging radiomics, because there is a different category of PET parameters that can be derived. It is not just the bright thing that we see on the qualitative assessment of the PET image. There are a lot of quantitative parameters which can also be derived from the PET. And if we are able to do that, it has been shown in the studies that adding PET to all these MR radiomic parameters can definitely enhance the capability of predicting this response to therapy. So all those cancers which are showing a lesser FDG uptake are likely to go ahead with a better response than compared to those who are showing a much higher FDG uptake or a much higher tumor volume.
Yeah, but somehow I feel ultrasound does not have that sensitivity as the MR or PET that could really help us, early on in the treatment as the sensitivity and specificity the MR has.
Yes, of course. But what I feel, Dr. Jyoti, in my practice is it may not be the primary ultrasound that was done. But if it is a second look ultrasound dedicatedly done to look for either it is an additional tumor in the breast or an additional lymph node that has been identified on MR, I think ultrasound adds a lot, and it can definitely, I think in 80 to 90% of the cases, it can identify that lymph node which was shown on MRI or PET to be avid.
Can I add a bit here?
Yeah.
Ultrasound, if it is done along with shear wave elastography, it has good potential in seeing response, as we have demonstrated in one of our studies. And with the AI, like the way Vinita showed that abstract, I think there is good hope that ultrasound in future may be a good modality for a response assessment after NSET.
Yeah, and we need such things because ultrasound is one modality which is very readily available.
Yes, and shear wave elastography will make it quantitative as well. It will not be completely operator dependent. You will have values to say that it is, the stiffness is decreasing, and that will be a surrogate for response.
So we can objectively then measure these parameters. Okay. So this was the abstract, the poster that was presented last time in 2020. And this very clearly shows that if we are able to predict response, then as even Dr. Meenu had just now specified this. So after 12 weeks of taxanes, if the MR which is done at baseline at 2 weeks and at 12 weeks. And if it is very confidently telling us that, you know, there is a complete pathological response. So in this, in one of the arms of I-SPY 2, they're also doing biopsies and confirming that, yes, there is a complete pathological response. And when we are 100% sure that there is this response, or there is this good response, then they are very confident about skipping or omitting, 4-week bi-weekly cycles of anthracyclines and going directly to surgeries. So this is one area where if we can, very confidently predict early on in the treatment that, yes, there is going to be complete pathological response, or there is a complete pathological response, then we can de-escalate the oncological treatments and save the good responders from the toxicities. This was another study where they had taken the integrated model for early prediction of neoadjuvant negative breast cancers. Again, they said that total volume reduction and if it is stage. So this is what I was talking about just before starting the panel discussion. So it's more likely to be an integrated approach. So here they are taking into imaging, they are taking clinical stage, that is they are node negative. And if TILs are less than, more than 20%, then these are the patients who are likely to have a much better response if we are taking all three into account rather than just one parameter into account, and then we can predict complete response. So now coming to the surgical management, we have seen how things have de-escalated, or the management has de-escalated in the breast. Now going a step further, we had today seen the small trial. It's an ongoing trial, so we'll be very, seeing the results in another couple of years, whether we can omit surgery in early breast cancer. And in the another scenario, that is if there's a complete response post NST. These were the trials which were presented by Dr. Rupa and Dr. Smriti, whether again we can omit surgery and do the excision using a WAB. So let's hear from Dr. Kanchan. What is your take? Do you think there is any promise, or do you think this is just a hype and there is no hope in these kind of trials? Dr. Kanchan?
Yeah, good afternoon. Thank you for having me on, and what a wonderful learning session this has been. So radiologists are in a very exciting space right now, unlike us surgeons, because we are seeing our work being cut more and more. But it is an era of benefiting the patient, where we are going from a maximum tolerable treatment to the minimum effective. And I think we all have to look at these trials and look at these thought processes with a very open mind. But at the same time, we have to take them with a pinch of salt unless we have enough validated data to prove that these are going to be successful in the clinical scenario, and also identifying the right kind of patient in whom these can be, later on applied. Now, coming on to, trials which are looking at either completely radiologically, under radiological guidance, without a surgical cut, removing the tumor, versus, checking to see whether we should go back to do surgery in an exceptional clinical responder in the post-NAC setting. So I'll talk first about a little bit about, the small trial, because all of us come with certain biases in mind on how we have been taught to approach oncological treatments. And as surgeons, one thing which is deeply rooted in our psyche is that if I am surgically removing a tumor, the margin status plays a huge role in determining what kind of adjuvant treatments or whether further surgery is needed. And when we are looking at trials which are looking at just radiologically pulling out the tumor, margin status, is it going to be that effectively determined or not, is something that remains to be seen. And in patients in whom you are downgrading or de-escalating to not doing breast surgery and just radiological extraction of the tumor, are you then going to do something for the axilla, which is also that minimized and that de-escalated? So I think that needs to be looked at, and definitely not something that we can wave off as something that cannot be implemented in future practice. I think as screening becomes more and more advanced and we find more and more small tumors, definitely patients will benefit from minimal surgical intervention. Coming on to the post-NACT, I think that's a huge discussion, and Dr. Smriti also just spoke about it. See, we have to balance, because the data up until now for VAB, for bed biopsies in post-NAC patients has not given us the confidence, because the FNRs are very high. But the AI model that has been applied to VAB has suddenly shown huge promise as being able to predict, and again, we have to take that with a pinch of salt, because that was a smaller study. Now, we have to also look at this from the patient's angle. Yes, we're very excited as radiologists and as surgeons that we're doing less. But think of it from the patient angle. You've done bed biopsy and shown that there is no residual tumor, so the patient hasn't gone on to surgery. But are you increasing the amount of imaging that the patient is going to have over the next couple of years to ensure that she doesn't have a recurrence? Will that imaging be more frequent and more invasive than if she had had surgery? And also, are you increasing the anxiety of the patient, knowing that, oh, I did not have surgery, but only a few biopsies were taken? So I think all of these things require a multidisciplinary approach. I think right now standard of care is not to do bed biopsies, and if it shows that there is node negative, we don't go, if there is response, we don't go ahead and do surgery. Because also, I'm sure Dr. Meenu will agree with me on this, that PCR and residual cancer burden has a huge role to play in determining what kind of adjuvant medical management they're going to offer. And we do know from the CREATE-X and the TDM1 trials that in patients who had residual disease, adding other treatment modalities in the adjuvant setting like TDM1 or in the CREATE-X capecitabine did lead to better outcomes for the patient. So I think we have to look at all these angles. It's quite multifactorial. One study does not help us determine how our practice is going to be, but definitely gives us enough food for thought to see, are there patients in our practice to whom we can extrapolate these, and then look at our own data to understand whether we are now ready to take the next step to de-escalate.
Right. Thank you, Kanchan. Very well said. A couple of things that I wanted to add here, that for early breast cancer, the radiologists are always blamed for overdiagnosis, and then obviously it leads to overtreatment. So this might be, filling up that gap where we are picking up small cancers. We cannot sort of leave them thinking that, it's a favorable cancer, so it's unlikely to go ahead and cause any damage to the patient. But yes, if we are doing VAB and removing them, then that over treatment and over diagnosis, we can bridge that a little bit. And also for the margins, now I've read a couple of studies that said that what they are doing is they're removing the cancer, they're putting that in a one sample bottle, and then they are doing the margins again. So, and that goes into the other, another bottle, and then the pathologist tell them that the bottle which had just the margins, is there any residual disease in that, so that, you can take things forward from that level. And for the complete response, that MD Anderson trial that was presented by Rupa, where it has added AI, as you rightly said, is really adding a new dimension. We really don't know why few patients respond and the other don't. But when we are putting AI, it is really, giving us that insight that these are the ones which are likely to benefit from de-escalation. So, Smriti, do you have anything to add to this? You do a lot of VABs.
Yeah, Jyoti, I think I also had a lot of hope for VAB being the modality where we could, do it after NSCT and de-escalate surgery. But I think the key is proper selection of patients, because the response to NSCT is variable in various subtypes, and then to make sure that our sampling is extensive and representative, so which can be done if you make it mandatory that a marker clip should be deployed and then retrieved at the time of VAB removal. So the trials up till now have not been very hopeful, except the trial which used AI, and the AI was basically used for patient selection. So proper patients were selected, and we could achieve a FNR of 0% there, which is very, very impressive. So I have hope that with the refinement of our selection criteria, there is a way forward.
Okay, so that's interesting. So this takes us to our next topic. In the surgery, we have seen about de-escalation in the breast, and now we would like to say how we can de-escalate surgical management of axilla. So, so we have come from a phase where ALND was being done for all the patients to now SLNB, and I would like Dr. Kanchan to explain to us the management of axilla in a clinically node negative who is going for an upfront surgery. So what are the criteria? How do you manage those patients, and what are the areas where we can de-escalate?
So, in a clinically node negative, the gold standard is a sentinel node biopsy now, and all centers that practice breast surgery as a specialty, if they do find in a clinically palpably node negative patient an abnormal lymph node on ultrasound, they will get an FNAC to prove or disprove that this patient is node negative. So in node negative patients, it's fairly straightforward. We do go ahead and do a sentinel node biopsy. But when we are talking of de-escalation in axillary surgery, we are now reaching a point where we are saying that in the clinically node negative patient, can we de-escalate to the point that a sentinel node also not be done? So that is something interesting to watch out for.
Right. So can you just let us know about the various trials that have helped us to reach to this conclusion from ALND to SLNB, and then take us forward to the next level where we are thinking not to even do SLNB. So what's the various trials that have come?
Yeah, so the timeline for how de-escalation in axilla has happened is quite interesting, because data by default were gathered from studies in which they may not have had potentially at that time thought of the kind of results that they would produce, and it goes back to the NSABP B04 study in 1970, where I don't think such kind of a trial would be allowed in this day and age. But they were able to randomize patients into undergoing what was a radical mastectomy and the standard of care at that time. And then they divided patients into those who had the radical, patients who had a total mastectomy with treatment of the axilla by radiotherapy and not by axillary clearance. And then they had a group of patients in whom patients underwent only breast surgery with no treatment of the axilla. So neither axillary lymph node dissection nor axillary radiotherapy was done. And the impressive results from this, or what we gathered from this, was that in those patients who had the axillary nodal dissection in that arm, the node positivity rate was around 40%. So we would obviously then presume that patients who did not have axillary surgery also had an axillary burden, which was there in 40% patients. So you would then extrapolate to see that if you leave behind those nodes in those 40% patients, it should affect their recurrence-free survival, it should affect their overall survival. But surprisingly, only 17.8% of patients in that arm that did not have any axillary treatment had an axillary recurrence, whereas the remaining did not. And there was no significant overall survival or recurrence-free survival change. So this then led on to the very famous studies, the Milan, the Almanac, and the NSA-BP B32, which then spoke about or brought about the change in how we approached the axilla, and the concept of sentinel lymph node biopsy came around. So those who were clinically node negative, so node positives were still going straight away to axillary clearance, but those who were clinically node negative were having a sentinel lymph node biopsy. And the standard of care in these surgeries was that if the node is positive, the patient shall proceed to an axillary dissection, whereas if the node is negative, then you can spare the axilla. So that was the first big step that we proved through studies to say that yes, we can spare the axilla. And there were so many, I think for want of time, I'll quickly go through then the next thought process was that even in the node positive patient, do we really need to do an axillary clearance? Because 60% of patients who underwent axillary clearances did not have non-sentinel node involvement. And please understand here that we are talking of Western data where tumors are in early stages. We are not talking of Indian data. It would be a dream for us to have 60% patient not have the non-sentinel node involved. So for students who are listening in, we can't just extrapolate this, but yes, that's got them thinking that can they spare the axilla in these patients? And the Z11 was the first trial that looked at it, was beaten black and blue because there were too many lacunae in the trial. But then other trials that came around, Synodar 1 and those that looked at validating Z11 have been able to validate, and now it is standard of care in the West, and hopefully us Indian surgeons will also take that step very soon, that in the patients who have less than 1 or 2 lymph nodes involved and have a favorable histopathology, are we okay to de-escalate and not do an axillary dissection? So those trials, none of them, all the trials that Dr. Jyoti just showed on the previous screen, did not show increase in axillary recurrences, did not show significant, change in overall survival or disease-free, distant recurrence-free survival. So now we know that in patients who are clinically N0, and they've had upfront breast cancer surgery, 1 to 2 node positive patients, you can de-escalate and you do not need to proceed to do an axillary clearance. But what is the role of axillary ultrasound? So
you have been talking about clinically node negative, and you decide then when to do sentinel lymph node and when to do ALND, and it's all on clinical
Can I
scenario.
mention something here? Jyoti, when we are talking of de-escalation in the breast, I know my radiologist will tell me there are 3 tumors, 4 tumors, this tumor measures this size, it is this much distance from the other tumor. But in the axilla, you're not going to tell me I can see 20 nodes, one looks abnormal, the rest look normal. So I think that is where the role of axillary ultrasound needs to be refined if we have to have the confidence of axillary de-escalation. So I'll let you go ahead and ask the radiologists.
Okay, so Dr. Smriti, what's your take on axillary ultrasound? How sensitive they are? What's their specificity? And also, Dr. Sangeeta, what do you think is the role of MR and PET in evaluating axillary lymph nodes?
Yeah, so Kanchan, I completely agree with you that the confidence that the radiologist can generate on ultrasound when there are multiple nodes involved, and plus with the higher rate of reactive lymphadenopathy in our Indian population, that leaves much to be desired. So I have done a feasibility study in my institution for clipping nodes and trying to see if we can remove all the disease in the responders after
Smriti,
CT.
yeah, sorry to interrupt, Smriti.
Yeah.
We were just talking right now on the upfront surgery, not NST patients. So if you could just tell in the routine, breast cancer, if what's your this thing on axillary ultrasound, how sensitive it is, and
Right. The sensitivity is quite good, but the problem is specificity, because often it is not possible to differentiate reactive lymph nodes from metastatic, because they could have diffuse thickening as well, and that is the commonest finding in metastatic lymph nodes. So over there, we tend to be overdoing our axillary biopsies, and that's the reason we have to prove by biopsy that a particular lymph node is metastatic or reactive. But I do find the Stavros teaching very helpful, that you must look at the contralateral axilla as well, because if the lymph nodes are all looking similar on both sides, it's likely reactive lymphadenopathy. So yes, ultrasound is as yet not specific enough. So it has to be followed up with an axillary FNAC or a biopsy in suspicious nodes. Yes.
if it is a smooth cortical thickening, what's your cutoff when you start putting needles in it? Is it like if a cortical thickness of 3 millimeters or more that you put a needle in, or
I have had a big learning curve here. Initially, I was putting in needle right at 3 millimeters and more, and I ended up with lot of negative biopsies. So that means I was biopsying too many non-metastatic nodes. So slowly I have refined the criteria, and now I only put needle in diffuse cortical thickening if it is a unique node. If the other nodes around are looking more normal, it should not be that all the nodes are looking same, because it's unlikely that in an early stage cancer you'll have metastasis to so many nodes. So looking at the primary tumor also is important. If you are getting a primary tumor which is about 2 centimeters and then multiple nodes with diffuse cortical thickening, it's more likely that it is reactive. So I would not put my needle there. So more than the 3 millimeter thickening, it is how the adjacent nodes are, what is the overall picture. I always do a contralateral axillary ultrasound also to try and make up my mind whether I want to put in a needle or not.
Dr. Sangeeta, what's your take on axillary lymph nodes on PET and on MR?
So now, since we are talking about the primary at the time of primary diagnosis, I think when we are doing a PET MRI here at Apollo, or even if you're doing a PET CT and an MRI, they have an additive advantage in improving the specificity of the identified node. Besides, being sensitive enough to diagnose more nodes that can be done on an ultrasound. So there are similar criteria on MRI which I usually follow, and even the smaller nodes less than a centimeter with high resolution MR images, I think we are able to a certain level discern that this node seems to be involved and this doesn't. Though I have not been able to, accumulate the data and analyze it for my own benefit, for our benefit, but I think that MRI, and then if the PET uptake is also shown at that enlarged on that small node, it adds to the specificity.
So basically, if on all three modalities, like it's a single abnormal node on ultrasound which is showing uptake and it's looking abnormal even on the MR, then the specificity goes high. But just on single modality, and especially if you don't have those typical features where you have loss of hilum or you have an eccentric cortical nodule, then just relying on the smooth thickening, then the specificity obviously goes down with axillary ultrasound. Yeah.
Of course, granulomatous nodes in our clinical practice, they are the add to the dilemma. But as Smriti rightly said, then you are usually, likely
Have
to find
multiple.
a bilateral node or a high node up in the, neck or anywhere else in the body. Then that adds to the,
the decision making
for us to take decision. Yes.
Going on to patients who are undergoing neoadjuvant chemotherapy or systemic therapy, but they're clinically node negative. Dr. Kanchan, how do you decide when are you going to do a sentinel node biopsy? Is it before starting the chemotherapy or is it after systemic therapy?
There has been an evolution in the thought process of the timing of sentinel nodes in patients undergoing NACT. Initially, we would do a sentinel node biopsy prior to NACT because the thought process was that NACT may alter or disrupt the normal anatomy of the lymphatic channels, and you may miss the normal sentinel node because then the node that you find as sentinel may not be the true sentinel if there has been complete response. But then studies over the years have shown that you can safely perform sentinel node biopsy in a CN0 patient after completion of neoadjuvant chemotherapy, and even in our practice that is what we have done. We have moved from doing pre-chemo sentinel node to doing a post-chemo sentinel node, and there is no difference in the efficacy.
Right. This was a meta-analysis of SLNB after NAC. So as you said, there was a lot of dilemma, but there have been few good meta-analysis that helped the surgeons take the decisions that they have taken of doing SLNB. It's technically feasible and accurate for axillary staging in the initially clinically node-negative breast cancers after NAC. But what about de-escalation in clinically node-negative patient who become, in clinically node-positive patient who become node-negative after NST?
So, if you look at standard of care now, that, if a patient who was clinically node positive prior to chemo becomes clinically node negative after chemo, can you de-escalate in the axilla and not do clearance? There were multiple studies that were done, but in those cases, what we have to understand that it cannot be the routine sentinel node biopsy procedure alone, because the FNRs in these patients were high, and we then realized that doing what is called a specialized or a personalized sentinel node biopsy, in which you have added other things, like you're definitely using dual markers for identification, you're using IHC, and very importantly, you are identifying 3 or more sentinel nodes. So this is what is called the plus sentinel node or the added sentinel node, whatever you may call. So rather than just doing the routine sentinel node, if you are able to do targeted axillary dissection, identify 3 or more nodes, you do IHC, then the FNR rates fall significantly below the 10% mark, which 10% we think is the magical number. And yes, in these patients, you may skip clearing the axilla. But standard of care right now is that even if there is micrometastatic disease in a node post NACT, then clearance is done.
Right. That is what we are doing in Indian population. But like in the West, people are now more and more, doing, as you said, the plus SLNB and trying and avoiding ALND. So what's the role of clipped node? So it helps then to reduce the FNR of these sentinel node biopsies.
So see, the premise is that if a lymph node was looking abnormal on ultrasound prior to chemo. This was the lymph node in which you did the FNAC and proved that it was a metastatic node. After response, when you do a sentinel node biopsy, is this node going to be the same node that you had FNA'd? In fact, in studies that looked at targeted axillary dissection, in about 20% cases, the sentinel node was not the clipped node. So clipping of the node, yes, would help to ensure that the lymph node that was FNAC proven to be metastatic is retrieved during surgery and analyzed on the same thought process that we have for a clipped tumor bed in the breast. So the thought process is the same, that we are ensuring that the initially biopsy or FNAC proven lymph node has been retrieved to study the response. And clipping a node does help the surgeon to definitely reach that level of confidence. And clipped nodes, in fact, even we tried in our setting, but cost becoming a big issue. But for the 6 or 7 patients that we did, at least, we realized that all our sentinel nodes were the clipped nodes, but that was just 6 or 7 patients that we had done. But I believe Dr. Smriti has a larger number of series.
So I was just going on to Dr. Smriti. Dr. Smriti, what's your experience of clipped nodes? So this is the study that Dr. Smriti has shared with me. So I'm putting it up for the benefit of our viewers.
Thank you, Jyoti. We did try clipping nodes and trying to see whether the removal of clipped node will add to the response assessment. And the gold standard was axillary lymph node dissection. As in my institution, we are still doing axillary lymph node dissection for node positive patients, even if they become node negative. We are not really doing post NSET plus SLNB. So the number of eligible patients, though we clipped about 69 patients, but the number of eligible patients who underwent surgery in our institution were 32. And in that, we got a very good FNR of 4.8%. When you add the post-NSET ultrasound findings and the clipped node histology, the clipped node histology alone was 28.6% FNR, which is little high. So that means that is because our patients are little advanced and most of the patients had more than 3 nodes. So you cannot just comment on the clipped node histology. There are other nodes also. So in the post-NSET ultrasound, you can see whether those nodes have resolved or not. Out of the 32 patients, 10 patients had less than 2 lymph nodes involved. And in them, we had a good result of this study.
Sorry to interrupt, ma'am. You are left with just 2 minutes to conclude your panel discussion. Thank you.
Okay. So I just wanted to ask Dr. Smriti how easy it is to put wires after putting clipped nodes. Obviously, it becomes difficult.
What helped us in achieving a high rate of success in this feasibility trial is the fact that we were seeing these lymph nodes after every cycle. So we had a visual map of the lymph node which was biopsied and clipped. So it was easy to identify the clip because we knew where to look for it. And in fact, we could clip the nodes in all but one patient. Locate the nodes in all but one patients. Mostly with ultrasound, and wherever we were not sure, we put a ultrasound guided wire also. In 2 patients, we put a stereotactic wire for locating that clip node.
Dr. Smriti, can I quickly ask, since you do have good experience with this, when we were and I know this question's been asked many times, it's not always just that one node that you have FNA'd and clipped. Sometimes there might be 3, 4, 5 abnormal appearing nodes, and which node do you decide is going to be clipped? Because you're not going to put clips in every single node. Then does targeted axillary dissection actually become that targeted after completion of chemo because we clipped only one node?
That is absolutely a valid point, and that is why the result of our study was that we should be doing this only when the maximum number of nodes involved is 2. So it should be a oligonodal scenario, not when once more than 2 nodes are involved. I think that patient is anyway a candidate for ALND then. If you want to de-escalate surgery with targeted axillary dissection, we should choose patients who have less than 2 abnormal nodes on the pre-NSCT ultrasound, and it would be better if we clip both the nodes.
Excellent, thank you.
Okay, so all those, there are other options also available for wireless localization, which are the radioactive and the magnetic seeds. That's a food for the thought, and maybe in future even we can start doing in our country. And these were the abstracts that were presented in last time SABCS on these two this thing. So in summary, when we come to axillary lymph node management, I think Dr. Kanchan has very rightly put that we have come from ALND to SLNB, and now we are coming to a stage where we can even think of omitting SLNB, and in patients with neoadjuvant chemotherapy, if we are clipping the nodes and we have like FNA or biopsy proven lymph nodes, in selected patient group, we can still omit ALND. That would be, right now we may not be doing it, but that is one thing that we would be really looking forward by accumulating our own data, that even in node positive, if we can just stick to SLNB rather than doing ALND. So with this, I would come to my last question. Dr. Kanchan, what are the challenges that you face in Indian population? You have such thorough knowledge, and you would really like to de-escalate as much as possible. But what are the challenges that you face in doing so?
So, when I talk about challenges, I think challenges that the Indian oncologist faces are at multiple levels. So the challenge that a doctor who is practicing in the periphery is facing is very difficult from someone in a government setup which can afford to give the latest treatment, to the private sector where we would love to give everything, but obviously cost is a factor. So what I want to say here is, before we talk of challenges, what is important for us to understand is that it's very exciting to hear about de-escalation studies, but we have to definitely slow down and understand whether we have reached that level of maturity as breast clinicians. And when I say clinicians, I'm including my radiologist, pathologist, and the entire team. Have we reached that point? And the biggest challenge is that we have not. We still suffer from very poor, I wouldn't say very poor, but we don't have specialized radiology services available. And we do know that if we are going to de-escalate, which is what the topic of discussion at SABCS this time was, then we do need a very good and thorough radiology support, which is a challenge that we face. Also in the Indian population, even in centers like ours where we have the best of radiology available, is our patient able to afford it? One. Secondly, is our patient intelligent enough to do informed decision making? Because you might tell the patient, I can clip this tumor, it will downgrade and I can do breast conservation. But a general surgeon sitting in the community will tell them that is risky, just remove the breast, just remove the lymph nodes. So that's a big challenge we face. And I think when we meet at meetings like this and all the experts are together, I think the onus is on us clinicians to also pass this message down to the general practitioners, because they sometimes play a huge role in making the patient decide what kind of treatment they're going to have. Another challenge, I think, in the Indian population, which we all harp about, is that patients come late. And if they are coming at later stages, then obviously the extrapolation of Western data, where they see early breast cancer and a different profile of breast cancer, we cannot just extrapolate until we all have done our own validation studies. But the future is definitely looking bright, and I'm sure we all stand to learn a lot as we go along, and conferences like this, which have been beautifully organized, help at least us to understand these challenges and how best we can look at overcoming them.
Very rightly said, Kanchan. Dr. Meenu, do you have anything to add to the challenges that you as clinicians who are actually, facing the patients, any more challenges that you feel that you face with the Indian population? And also at the end, if you could give the closing remarks before we close the session for today. Dr. Meenu.
Dr.